Right, I think we'll start this session because we don't have very much time. Can I encourage you to come in a little bit if you feel like it? It feels like a very spread out group. There's masses of seats in the middle if you would like to move. We're in for a treat this afternoon because we have two fabulous speakers. Paul Jenkins, who is CEO of Rethink, the mental health organization, and Mulley from Dartmouth in the States, from Dartmouth Medical School, who has done a huge amount of work on patient engagement in decisions about their care. I'm going to kick off. I'm Angela Coulter. I work for the Informed Medical Decisions Foundation, also in the States, and for the Nuffield Department of Population Health at Oxford University. And today, the King's Fund has published a report on the House of Care. You've already heard quite a lot about the House of Care already today, but I wanted to just briefly explain what it is in a little bit more detail, if I can get the machine to work, which I can't. There we are. The House of Care is a very important concept, as Martin and others explained when they were speaking just now. And it's important because it's both a metaphor for a whole system way of doing things, with patients right at the centre, but also a checklist for those people wanting to implement it. And so the detail of it becomes quite important. At the centre is what I prefer to call personalised care planning. And by the way, if you're interested in any of this, you can pick up the report downstairs at the King's Fund stall. Personalised care planning is a collaborative discussion between the patient or the person with long-term conditions and the health professionals who are there to help them. Preferably with one health professional in the lead, or possibly a social care professional, to help them coordinate all the inputs to their care. Now, the roof of the house is the organisational processes, and this model has already been implemented. It's in the process of being implemented in various general practices around the country. It's very much a primary care-based model. And one of the things those practices have discovered is that in order to make this new way of working, and it is indeed quite a new way of working, to make it work, they need to put all sorts of organizational supports in place. They also need the commissioners who commission their services to be very supportive of this approach, and they need to put various organizational processes in place. But for this session here, we're going to talk about the two walls of the house, without which the house would fall down. And the two walls are the informed, engaged patient and the kinds of supports they need to have more control over their care, and the healthcare professional who's committed to working with the informed, engaged patient and the kinds of supports they need to make this work. As Martin said, this is a proactive, holistic model of care. It's the kind of things that patients have been calling for many years, as Jeremy told you. But there's plenty of research which shows that this doesn't happen just by chance. This has to be worked for. This is really different from the way most primary care is currently organised. So building this house is tricky and needs a lot of thought. So for this session, we're going to start off with Paul talking about the patient's wall and the kinds of things that patients need to be more engaged, to have more control over their care. And then Al is going to tell us about the professional side of the house, what professionals need to do and what kind of support they need to make this personalised approach, bringing in shared decision-making, personalised care planning into the centre of the house and to transform care that way. So without any more ado, I'm going to hand over to Paul.
Thanks very much, Angela. Good afternoon. So work out how the IT works first, and then I'll be away. There we are. Great. So in a short while, I want to just give a couple of perspectives on why involving patients and treating patients as partners matters. Draw on some of the experience of my sector in mental health, which in a number of ways is, I think, ahead of the game on some of these issues because of some of the particular history and experience of people who use mental health services. And then actually to give some thoughts on one mechanism for actually closing the gap between professionals and patients, and that's actually the role of patients to act themselves as professionals. So why does involving patients, why does treating patients matter? I mean, clearly for me, this would be a good thing in its own right, but it is made absolutely essential because of the paradigm shift that we've already alluded to of moving from a health and social care system that is based on demand of infectious diseases to one that is based on long-term conditions. And I think the trick is in the title. These are long-term conditions. These are long-term relationships that individuals have with the health and social care system. There are also conditions which do not lend themselves necessarily to cure in the traditional sense. What the objective often is around the long-term management of those conditions, often the long-term self-management of those conditions that allow people to carry on with their daily lives and achieve the goals that they want to achieve in their lives. So I think the very starting point of involving patients in decision making must be around actually their role in defining the purpose of healthcare interventions, which has to be seen through the individual lens of their lives and their experience. So if I've got diabetes, I might want to control my diabetes because actually I want every Friday to still be able to have a pizza with my grandchildren. If I've got psychosis, I might want to be able to control my voices because I want to still have a relationship or I want to stay in my job. And if you start from that individual definition of the purpose of healthcare, then you can move on to design services which much better meet the individual needs of those patients. So, for instance, if you're delivering psychological therapy, if patients say that they're more likely to engage with that therapy and be involved in it, if that service is provided in their own homes or in the more anonymous setting of doing it through the phone or the internet, then that actually will probably be a more effective intervention. Because at the heart of services that are better designed around patients' needs, you're likely to create the environment where patients concord with that treatment more than if it is just imposed on them and they have to just do what the clinicians tell them. So again, use the example from the mental health field, Will. Taking antipsychotic medication is not a particularly pleasant thing. It has significant side effects, and yet it is a crucial cornerstone of supporting people with long-term serious mental illness. If, as a patient, you have had a say in which medication you are on, in terms of balancing the effectiveness of that medication against its potential side effects that reflect some of the things that are important in your life, you are more likely to accept and be comfortable with taking that medication than if, again, you're just given it and told to take it. And all of these things in the round, for me, build a cogent argument of leading to more effective decisions about the use of resources, either in the sort of the specific case of I mean, the oft-quoted example about prostate cancer treatment, that if properly explained and given choices, more patients will opt for chemotherapy rather than invasive surgery, which is more cost-effective for the system, or at a global level, because actually if we target our healthcare interventions on the things that matter to patients and achieving the outcomes that they want to achieve in their lives, they are less likely to be caught in a revolving cycle of a heavy use of the more acute and costly parts of the system. So, if that all makes sense, which I think most of us would regard it does, why hasn't it happened? And there are a number of obviously clear barriers. I think we have to be upfront. The most important and most significant one is a cultural perception of power and perceptions of power. Doctors and other clinicians are used to being on top. They're used to having respect for their scientific knowledge and their significant training. And they are used to a paradigm where they give instruction and advice, and patients, as the name suggests, meekly experience that and follow it. We are talking about a model of care which is very different here. And power is a zero-sum game, and there has to be some acknowledgement of giving up that historical power and authority if we're to move on to a new model. Communication skills, I think, come significantly into the picture, although I think vastly improved and changed from the past. I don't still think that the effective skills and techniques of how to involve people in decision-making, how to communicate effectively with patients, how to take a coaching rather than an instruction model are yet firmly enough embedded in clinical skills and clinical training. That difficulty around communication can be exacerbated when people don't speak the same language. If one group of stakeholders sees the interactions in terms of clinical measures, in terms of purely biological purposes, whereas other people see it in terms of the psychological impact of an illness on their lives, the ability or issues about how they carry on managing the things that they want to do in their lives alongside an illness, you're never going to get a meeting of minds. And then the practical issue: we don't organise clinical consultations, clinical transactions in a way that creates the space to have this kind of engagement with patients and in other cases their carers and families. And yet that's daft, isn't it? When you take that view, these are long-term conditions, you think that actually when somebody develops a condition or multiple conditions, they may well be entering a period of long-term relationship with the NHS and use of its services. Isn't it sometimes worth us rethinking the paradigm of how we organise transactions, so there is the space right at the outset of the experience to give people the input and the support that allows them to be effective owners and managers of their condition. I wanted to draw on some of the experiences from mental health, because I think in mental health there has been a longer-standing tradition around service users or patients trying to take ownership of the agenda of care. And that's gone by the shorthand of the recovery movement, which started back in the States in the 1970s amongst people who'd had long-term experience of the psychiatric system, and not often a very good experience of the psychiatric system. I think one of the most important things to highlight about it is this is not a set of reforms that have been rolled out top-down. This isn't a clinical initiative. This has actually come from groups of people who use services, trying to assert their own philosophy of life, trying to take control of the agenda themselves, often, at least initially, in conflict with clinicians. And I think that has given it a strength and an authority that perhaps doesn't come if it's part of a sort of, say, a top-down initiative. At the heart of the recovery movement is a very strong value given to the experience of an individual, their own experience of living with their mental health condition. It puts the paradigm of patient-defined outcomes right at the fore. So what I might want is carrying on having a relationship, might want to be able to keep my job. I can do that possibly while I'm still hearing voices, as long as they're properly controlled. The objective of my care in the recovery movement might not to be symptom free. In the recovery model, though, one of the key roles that professionals play, and that they haven't always been historically very good, I think, is holding hope. Particularly when somebody is first diagnosed with a condition, the task of being able to communicate clearly what is involved in having this condition, what the prospects of recovery might be, but to do that in a way that still inspires the person, the service user or patient, with a sense of hope that is the motivation for them engaging around activities of self-management and support. And then to use a lovely catchphrase that people in the recovery movement talk about, a model that sees professionals being on tap, there when the patient needs their input, whatever time of day and night that might be, whatever for, rather than being on top. And then finally, just one insight of one of the movements, to say, which is gathering momentum in mental health, which can help close the gap in building partnerships between patients and professionals. And this is the concept of seeing patients as peer workers, whether actually in a voluntary capacity or actually in a genuinely paid and professional role. There's a long tradition of this in mental health. Those who study the history of mental health services, a famous French psychiatrist from the French eras of the French Revolution, Philippe Pinel, who went into the hospitals of Paris during the Revolution, released all the patients from their chains and started a more modern approach to mental health care. But one of the things he did was actually in reforming the provision of care. He started recruiting patients as supporters and helpers in his endeavours, and probably the first known example of peer work in mental health. So we're used to the concept of the expert patient. We're used to the role that voluntary organisations, either a big national scale like ours or on smaller local scale, can play in providing round the clock or providing support to their peers who are going through the same experience. As an example, so we in Rethink Mental Illness have 120 peer support groups around the country. Many of those led by a voluntary coordinator. All we provide in Rethink Mental Illness is a mobile phone and pay for the bills for those individuals. Those coordinators are supporting 13,000 people in one form or another in a year, with some of the day-to-day traumas and difficulties that come with living with a severe mental illness. So there is enormous resource there of tapping in a voluntary and informal way, but in a much more systematic and organised way than we do at the moment, of tapping into a body of expertise that exists there, of people who've been through the same experience, who know the issues, who know some of the practical concerns, and who can support their peers along the same journey. There's also, I think, a case now for a more formal a role of employing peer workers, people with lived experience of a condition, as part of healthcare delivery teams. And I'm very pleased to see, building on experience of this in the United States, to see this becoming part of the design of mental health services in this country. And what's recognising here that there's perhaps a particular role and in using people with their own experience of that condition. One, to take a role that helps people understand what it means to live with that condition. Secondly, to understand around the treatment or care that's being provided and what some of the issues around that might be, but particularly to engage with the actions that individual themselves needs to take to support their own self-management and to support a recovery pathway. And as one very honest psychiatrist I've worked with said about this, if you're a young black man on an acute ward in inner London, who are you going to listen to about messages about your use of cannabis and how that affects your voices and your other symptoms, your mental? Are you going to go for, as he put it, an elderly Calvinist psychiatrist? Or are you going to listen to somebody from your own community with the same experience? So I think there is also an important role for peer workers. Supplementary to the role they play with their peers, though, they are also a really important part of changing the culture of clinical services and changing the attitudes of other clinical workers working alongside them. And then the final point I wanted to make is around the role of patients and service users as trainers. I think we are gradually going along this journey of having more input from patients and carers in clinical training. But I think we need to go a lot more. If you want to have a different culture in medicine and other professions, if you want to have a vision of care that is genuinely patient-centered, that needs to be built in to the very design of clinical training. It needs to be messages that people hear from the outset of their journey in training and throughout their careers in terms of refreshing their view and their commitment to that philosophy. And as I say, I think it's something that we're beginning to see more of, but I think one of the places where we could most significantly change this agenda for the long term is by fundamentally looking at the design of clinical training and getting much greater input from patients and carers into that. So thank you very much. Sorry.
Which one? How do I get my presentation? Okay, good. Well, thank you. I think that there's very little that Paul and Angela and I would disagree about on what's been said so far. As I try and engage you, just let me take a few seconds to ask for a show of hands. I'm wondering how many of you are here as patients and caregivers, how many of you are here are health professionals, and how many of you are here are policymakers. Good. Let's start with the patients and caregivers. Health professionals? Policymakers? Okay, good. Thank you. I've been asked to talk about the right wall of the House, and I will do that. But I would like to start off by saying that having been asked to talk about the clinician's perspective on engagement, what I'd like to do is to talk a little bit about the current pressures that clinicians are under, managing the present, managing the health of those they're responsible for under current circumstances and current policy environment. And also think about what it would take in order for the system to allow space to create a different future of healthcare. And then to get you to reflect a little bit with me now or later on what we have to selectively forget in order for there to be space to create the future, from the perspective of the clinician to begin with, but also from patients and policymakers' roles as well. And I'm going to start by describing what the problem is, with a particularly distinctive Dartmouth feel to it. How many of you have heard of the Dartmouth Atlas of Healthcare, or the NHS Atlas of Healthcare? Okay. So it all began 40 years ago when Jack Wenberg went to Vermont to demonstrate that patients didn't have access to sufficient number of health professionals and hospital beds in the rural area of northern Vermont. And he took a very scientific approach and developed an epidemiology of healthcare methodology so that he could look at the relationship between the epidemiology of healthcare and the epidemiology of health. And what he found was rather dramatically surprising. The people in rural northern Vermont did quite fine, thank you, even though they had far fewer doctors per 1,000 and far fewer hospital beds per 1,000. But where you lived in Vermont determined the care that you received. 6-fold differences in rates of hysterectomy, 4-fold differences in rates of prostatectomy, dramatic differences in likelihood of being admitted to the A&E or to the hospital. And he extended that model and that methodology across the entire United States, looking at 3,000 hospital market areas, coalescing them around the 306 hospitals or regions that had hospitals that could do advanced neurosurgery and cardiac surgery, just to get a sense of what he called referral regions. And in those regions, again, there were dramatic differences in inputs. Per capita number of hospital beds, per capita number of specialists, primary care doctors. And as a result of those different levels of inputs, the costs were dramatically different, 3-fold differences. In 2010, those differences ranged from $17,000 in one hospital market area to just over $6,000 in another hospital market area. So what's the obvious pregnant question here? Do we produce better health with more inputs and more costs? It took another colleague, Elliot Fisher, 7 years to answer that question, and the answer is a resounding no. With higher intensity and cost, there are no better outcomes in mortality and function. There's more difficulty for patients to see doctors with longer waiting times. There's more difficulty for doctors to admit patients to the hospitals and to obtain referrals. There are poor patient relationships between doctors and patients in the high-cost, high-intensity regions. What's going on? If you have all of this activity driven by the local capacity rather than the needs of the individuals, the capacity, driving the care, gets in the way of the kind of interaction and engagement that we're talking about. Now, this means that in the United States, we waste 40 cents on every dollar that we spend on healthcare, 40 cents on every dollar. The sources of waste and harm are failure to deliver care that we know to be effective safely. And often that care is the most basic. It's the easiest to deliver. It just doesn't get the attention that it needs. And you can recognize this phenomenon when you see outcome variation and study the processes and look for associations between processes of care and outcomes. But other important sources of waste are overuse and underuse of care when the care delivered should depend a great deal on the preference of the individual patient. Different men feel differently about the trade-off between urinary function and sexual function that underlies the geographic variation in those rates of prostate surgery that I mentioned. Different women feel differently about the trade-off of breast-conserving surgery versus mastectomy. They feel different about the prospect of living without a breast, about the prospect of having cancer come back in a breast they chose to keep. If we don't engage patients and understand those preferences and even measure them, diagnose those preferences, then we're making fateful decisions in the face of highly avoidable ignorance on the part of the patient and the doctor. And if we make those decisions in the face of avoidable ignorance, we end up with a great deal of overuse due to the capacity we build. We call that supply-sensitive care. So the uninformed decisions at the level of the individual patient, because we don't have the kind of exchange between doctors and patients, health professionals and patients that we're talking about, leads to uninformed investment decisions or commissioning decisions in health system capacity. There's a very strong feedback loop here that is not recognized. If we have ignorance at the level of the individual, we're going to have ignorance at the level of the policymaker. Now, some of you think, oh, that's just America. They shut down their government because they can't get along. And it's a market-driven healthcare economy. This isn't our problem. Wrong. The Atlas of Healthcare for the NHS demonstrated 3-fold per capita variation in costs of care for cancer and heart disease. When Muir Gray and his colleagues took the same methodology, similar methodology, and applied it here. As I mentioned, across the 152 PCTs, 3-fold variation in per capita costs. And after the NHS plan from 2001 to 2008, when you invested a great deal in capacity to do certain procedures because there were wait lists and there were political difficulty and tensions, for instance, stenting for stable heart disease, stable angina, after you built the capacity, there was 8-fold variation across the country in the rate at which stents were used for stable angina, and almost 8-fold within London itself. You built the capacity without knowing the preferences, and the capacity drove utilization. So this isn't just about giving the right care to individuals, to be nice to them, and to personalize care. This is about your whole economy. It's about the Nicholson Challenge and the failure to reach the promise of the 2002 Wanless Report, which said that the NHS could save $30 billion a decade or two later if only they engaged patients. Now, it isn't a problem. This hypothesis is still strongly held, high prior by me. The problem is we haven't worked to do that engagement, in my view, because we haven't recognized the economic importance as well as the personal importance at the policy level. This is Angela's book. It's a wonderful book. If you haven't read it, you should. You probably all know a little bit about shared decision-making. The goal of shared decision-making is to allow the health professionals to diagnose the patient's preferences. It's to create this exchange of equally important bidirectional information. Here's what's possible to deliver to you in this system with these resources in this context. And the information that comes back saying, this is what would be valued. Surgery would or wouldn't be valued to reduce my urinary dysfunction, given that it's going to affect my sexual function. Without that equally important bidirectional exchange of information, we're all in the dark. We've talked a lot about self-management, similar tools. Motivational interviewing is a critically important part of good patient engagement. It's very time-consuming because it's all about how long the health professional can get the patient to talk to him or her about the discrepancy between their goals and their behavior. So you don't want to just focus on the one-on-one exchange. You want to get to scale at the community level. And we brought in some non-traditional voices and worked hard to develop games that people actually enjoy. So it isn't the knowledge power hierarchy coming at them, it's them having fun and learning some basics, in this case, for instance, about the importance of herd immunity. So you're not dealing with uninformed arguments, basic ignorance about immunization and its value to the community as well as to individuals. Now, very quickly, since I've been asked to talk about the patient perspective, this looks a little bit abstract, but I can go through it quickly. On the horizontal axis, you have level of training and skills among health professionals. So at the far right, you might have the duly certified specialist who knows mental health as a psychiatrist and an internist and can deal with the most complex problem. Down at the lower end, in terms of expertise, you might have the patient or the caregiver or a community health worker equivalent, a health coach. On the vertical axis, you have the difficulty of the task. Is it that difficult care planning or even neurosurgery at the top? Or is it the motivational interviewing? Which is really very simple. If we had more time, I'd go through it with you. And people with high school education or left, who have much less social distance, who are much closer to being peers, can be trained to do it very quickly. Now, if the doctor thinks that it's their job to do the motivational interviewing, it's never going to happen because they're down way, way below that 45-degree line, which distinguishes between inefficient care and ineffective or unsafe care. You follow me? They're going to recognize instinctively that asking people on a scale of 1 to 10 how important is it to you to stop smoking or drinking, and then getting them to talk to you for as long as possible isn't the highest and best use of their time. We need to build systems to do motivational interviewing. We need to do systems that focus on this bidirectional exchange of information, or it's not going to happen. So policymakers need to hold the system, hold the health professionals accountable for accurately diagnosing patients' preferences, for motivating them, and for the quality of teamwork. We need to get rid of the knowledge power hierarchy and create a gradient of knowledge and recognize that. And be sure that there's shared goals, shared knowledge, mutual respect among the team members, because that's going to lead to mutual trust. And get the patients to recognize that talking to the coach is actually much, much more valuable than I ever would have thought because of this shared knowledge, shared goals, mutual respect, and the kind of decision support tools that we just talked about. Now, in May of 2012, the King's Fund, together with Dartmouth, published this monograph, Patient Preferences Matter, Stop the Silent Misdiagnosis. And I'm going to close with some of the observations we made. What we were saying is that we need to challenge erroneous assumptions, first of which is that science alone determines needs and wants. What the patient cares about is critically important. Variation in care is the problem. Variation in care that reflects ignorance in decision-making at a geographic level, that's a problem. Variation between patients based on what they care about is not a problem. That's what we strive for. Patient choices about time and venue? No. Patient choices about what an individual patient cares about, what matters most to them. The market can sort out healthcare? I don't think so. Just look at America, 40% waste and harm. Commissioners can calculate need, not unless they have this critical data. Supporting accurate preference diagnosis would provide clinicians with more and better information about what patients want. If you collect this data, you can give it to clinicians. They can have a prior probability of this patient's preferences and then start with that and then work at it, refine it, based on the use of these decision support tools and their engagement with the patient. They don't have that now. They don't even recognize that there's a distribution of how patients feel about different health outcomes. But we also need to provide patients with more and better information about the options and the outcomes in order for that to happen. And I don't think it's going to happen in the NHS or anywhere else unless dedicated teams are developed to pursue this. Remember what I said, there are a lot of busy clinicians, a lot of busy policymakers managing the present. They don't have time to create the future. You need a dedicated team that has time to do that after reflecting on what parts of the past do we have to selectively forget. And I would put the knowledge power hierarchy that we've been talking about first on the list. Let me stop there. Thank you.
Thank you very much. I told you you were in for a treat. Now we've been allowed to go on until 3, so we've got time for questions and discussion. And I'm going to go first to, we have 2 members of the People's Panel here in the front row to ask if you have anything you'd like to contribute or questions you'd like to ask before I open it up to everybody else. Yes, please. Can we have a mic? Just coming.
Yes, I thank you very much. I thought that was fantastic. It put into words things that I've been thinking for the last 30 odd years, I'm embarrassed to say. One thing that always strikes me is that, and one thing I think worries patients and carers when you talk about self-management and preferences and so on, is first of all the suspicion that it's all to save money, and secondly that the costs to the patient and carer are rarely acknowledged, in the sense that it may actually cost you in time. You may have to take time off work to self-manage. It may actually cost you in money, which you may not be able to afford and no one will reimburse. I just wondered if you'd like to comment on that.
Paul, do you want to go first?
I think those are very reasonable points. I think it's probably the order in which you start the conversation. If you start with an understanding of patient preferences, rather than trying to push patient preferences in a particular way because you've already got an agenda about the way you want to design services. So the economic benefits to the system are a consequence of designing good care rather than a purpose of designing good care. Because actually, most people who live with long-term conditions want to stay as well as they can for as long as they can. I don't know many people with mental health problems who want to spend a lot of time on acute psychiatric wards. What they often do want, though, is the right intervention provided at the right time, and they begrudge, in a way, cost savings that mean that actually they are allowed to deteriorate, get worse, and have to deal with that before anybody does anything about it.
Al, I think this is an issue in the States too, isn't it?
Oh, it's an issue. It's an issue everywhere. It's an issue in developing countries. The thing about healthcare is that when you're talking about financial waste, you're often talking about concomitant harm. It's not like other industries. It's not like other service industries. If you're doing an operation on somebody that wouldn't want that operation for the sake of a little bit of avoidable ignorance, That's harm. That's battery. And there have been many studies that demonstrate that people make very, very different decisions about what they want when they're informed and supported in constructing their preferences. Now, this applies every bit as much to long-term conditions as it does to specific decisions. So it isn't about saving the budget, and I wouldn't want my remarks to be interpreted that way. But it is about the health of economies. It is about stewardship of resources that at some level are always going to be limited. What goes into healthcare doesn't go into education. And that's true everywhere. It doesn't go into other services. So the most interesting thing about this kind of thinking in healthcare is that the waste is very often associated with harm. If you just focus on, let's give people the care that's right for them based on who they are, what they care about, the way they can accurately imagine alternative health futures and make choices as a result, that's what the goal should be. It so happens that in most economies, including yours and ours, that would save a lot of money and allow it to be reallocated to the kinds of services within healthcare or outside healthcare that I think we would all value more.
And that summarizes really the goal of the House of Care, which is to produce care that's orientated around the patient's goals. And that means starting with finding out what the patient's goals are. Any other comments or questions? Yes, please, gentleman here.
Thank you. I'm Jazz Russell, formerly of the Affinity Mental Health Project at St Anne's Hospital in North London. Just after the riots a couple of years ago, we set up a project to monitor self-referred patients and their mental health by getting them to fill out some questionnaires on a weekly basis and turn their scores of their self-ratings and their mental health into colours. So we created a heat map of their mental health and social competency. And joining several of those up, we actually managed to make movies of the flow of their mental health. Mm-hmm. There's a poster downstairs, actually. People are welcome to go and look at it on personalised mental health care. But one of the things that came out I want to ask you a question about was that a lot of voluntary bodies that I was asked to go and work with, they were doing great work in the community. Unfortunately, they weren't collaborating with each other. And I coined a term at the time and said they're suffering from collaboration illiteracy. And I think literacy, that kind of literacy, collaboration literacy, I've just won some European funding to get it more present in London organisations and businesses. So I just want to ask you a question about that, because in the NHS, people talk a lot about collaboration, but I think it's kind of wishful thinking for a lot of people. They don't actually really know what that is and how it's executed effectively. Yeah. So I just want to ask you a question about that, which is, what do you think would be the best route to ensure people effectively collaborate to make patients at the centre of care?
I think there, for the policymakers in the room, I think there needs to be a very explicit exercise to think about what government in a planned economy does well and what can be done better elsewhere. And to be sure that the regulatory structure and the models for being sure that the capacity is right to deliver services is there. But then you need other measures if what you're trying to do is to produce social value. And I would argue that these measures of patients' preferences with long-term conditions and the services they need and want, as well as these measures of teamwork, would create a context in which people could collaborate and even compete in producing the highest social value. Now, ideally, you would want the competitors to join learning collaboratives. You would want those responsible for managing the present and taking care of the patients to also build these dedicated team units to try innovative hypotheses and implement them and see if it increases social value. But I think the measurement component is really important. I think a big problem is we haven't been measuring what's most related to social value in system design in healthcare.
So we haven't been valuing cooperation, in other words?
Yes, measuring relational coordination, to use Jody Gattel's term. Shared goals, shared knowledge, mutual respect. Who is doing that well? Let's hold them up, reward them, incent them to do it.
Something that, a term that's been coined by me in some projects we've been using recently, is there's a big focus on return on investment. Mm-hmm. But I've proposed that people look at a different kind of ROI, which is a return on intention. And focus on making a difference first and worrying about the money on a secondary basis. I know a lot of organisations just the other way around.
Yes, yes.
Can you just offer one final comment, perhaps,
on
how we might be able to achieve that?
There are quite a lot
So I was asked, I was recruited to Dartmouth from Harvard to lead this new Center for Healthcare Delivery Science. And a big part of the argument is we need to expand our definition of science to measurement of what people value when they receive it. And that's what I'm referring to as patient preferences. If you're trying to create social value, if you have an enterprise, government-owned or otherwise, that's trying to create social value, the measures you need to take the discipline of science and applying it to delivery, i.e. the measures of patient preferences and value, are the exact measures you need in order to measure social value. The aggregate of patient preferences is not the totality of social value. You've got to deal with the negative and positive externalities, is the language that the economists would use, right? But it's a really good start. If you have an aggregate measure of the value that's been delivered to individuals, and that's what I was saying, if you focus on those measures and you focus on teamwork, I think you'd see much more productive collaboration.
Thanks. I'm going to take 2 or 3 at a time. Yes, lady there.
Thank you. It's a comment, really. You mentioned about healthcare professionals and doctors not having the time to invest in motivational interviewing. And the problem is that, for example, we had a patient who went on a self-management program who had diabetes and was very activated after being on the program, went back to talk to their healthcare professional and ask about their blood glucose levels. And the doctor said to him, oh, don't you worry about that, let me worry about that. So my issue with that is that the healthcare professionals really need to understand some of the principles and have huge potential to undermine a lot of good work if they don't get the training and the skills.
Yes, very, very good point. Gentleman there.
Hello. I'm delighted that you mentioned about incorporating some of the learnings from mental health recovery into the long-term conditions agenda. I've been doing work with Tim Anstis on the overlap between peer support approaches and motivational interviewing. My question is, though, how do we convince the commissioners of education, the healthcare education? So there's a £4 billion annual budget for health education in England. How much of that goes on training people, and why aren't we doing co-training of professionals and patients in the recovery college approach? Why isn't it happening?
I'll let Paul answer that in a second, but there's just one more point over here.
It's along the same lines. It's partly about making sure we don't get into a conversation about training, actually. This is about light bulbs. We're talking about different paradigms, and it's not just about let's train everyone with MI, which we did, actually, for a while, and it didn't get anywhere because we had the patients weren't well informed, and the House of Care whole point is that you need all of these things in place. So I had a couple of very quick comments. One was, I love that paper, but I don't like the idea of diagnosing preferences, particularly, okay, when we're talking about decisions, sure, but when we're talking about living with long-term conditions, things change. They change minute by minute, day by day, and we always think of diagnosis as a solid thing. So we're very careful about not putting a new box around it all. And Paul's point about the doctors being used to it, I think that, it's not about doctors only, it's all healthcare professionals and that world, but quite often they want to do something different, but the system doesn't let us. The time thing again, and it's how we free people up. It's absurd quite often for people to be doing something different where they are. We need this whole thing to change. It's just to reinforce those points, really.
And Simon here is one of the people who's done more work on the House of Care than anybody else in the country, so clobber him afterwards. But I'm now going to turn to Paul first.
So to answer specifically the point about, I mean, I think there are two things. One, I do think actually we've let this one to some extent slip by. So we've sort of focused on the here and now of delivering care. And actually, I think there's a real case for targeting
quite a lot more attention of this movement on the provision of training and training education. And now that we've got health education in England, in some ways, there's a big front door which we can perhaps go and bang on and do that. Picking up the specific point, I think recovery colleges, you sometimes need a catalyst to bring these things to, whether people more widely are familiar with the concept of recovery colleges, but it is creating a concept or a space within mental health organisations to bring co-training together, either co-provision of training, so service users training alongside professionals, but also professionals and service users being trained together. And actually, I think that is, I'm really excited at seeing that concept develop in mental health, and I think it is a concept that mental health could export very well to other bits of the system.
Thank you.
Just very quickly, the diagnosing patient preferences was not the plan title for this. We were asked to by the King's Fund. I was asked as the first international visiting fellow to address three things: practice variation, shared decision making, and commissioning. And it almost immediately followed a wonderful monograph that had been done by John Appleby and others, and practice variation, a wonderful monograph done by Angela and Alf Collins, done on shared decision making. So I was sort of left with commissioning. So what I did instead was I recruited some non-traditional voices who hadn't been using the term shared decision making like I had for 30 years. And that was Chris Trimble. And his recommendation was, it seems like you're having trouble getting doctors to recognize the critical importance of this. What was most important to them when they were being formed as professionals? And I said, well, what we're most shamed about is missing a diagnosis. So that's what we were trying to do. We were trying to grab clinicians by the lapels and say, this is really important and it's your responsibility and you're just as accountable for it as you are for diagnosing a disease, because the consequences of a mispreference diagnosis are just as bad as a misdisease diagnosis. So that was the reason for that. And that's related to this whole training problem. What I said was, we need to recognize that we could train for a gradient of knowledge that doesn't have the power hierarchy associated with it. And if we are very explicit about how we do it and how we brand it, patients will be thrilled to see a coach. We've done this at Dartmouth. We've done this with a partnership with Iora Healthcare. I get my primary care at a place that has 2 half-time GPs and 10 coaches. I see the coach, my wife sees the coach, and I know it's better care than if I were seeing a doctor. They've been trained to do the MI. They've got enormous amounts of time to do it because that's what they're paid to do. It's better care. So that's this line that I showed you that with the inefficient versus the unsafe, I think is really important for doctors to understand. In order for them to execute their responsibilities in engaging patients and understand what they want, they need to rethink their role and rely much more extensively on a gradient of knowledge down to the patient and including the patient.
Thank you very much. I hope this has given you a taster for all the fascinating issues that are raised when you start thinking about a house of care, a new model with patients at the centre. Thank you very much to 2 excellent speakers, and thank you to you as well.